we're good to go.
Perfect. Well, welcome everyone to the California ACC FIT Virtual Bootcamp. We have here today Dr. Michael Gibson from from UC Davis, who's going to be doing a live Q&A to answer the questions that you guys had from his talk on cardiogenic shock. So Dr. Gibson, thank you so much for joining us today. We're really lucky to have you. Your talk was just so comprehensive. And I think as now second-year fellows, kind of looking at the topics you've covered, the range and the depth, it's just so nice to see that information out there for the first-year fellows.
Thank you, Stacy.
Yeah. Well, so I'm going to go ahead and pull up the questions that we've received. So the very first one is, what do I do with the impella in a patient who has a cardiac arrest, who codes? What about a patient who has a balloon pump or is on Ecmo? What do I do with the device itself?
So it's very different depending upon the device. So first off with the impella, so you'd want to set the performance level to the lowest setting. So we're talking a performance level of 2. So this will ensure that you don't really have any further suctioning or anything that'd be knocking your patient back into VT. So any suction event can sometimes knock your patient into VT, and this would help prevent that. That being said, I have had multiple times where a patient was coding and we left it at the current level. Everything turned out fine. So if you forget to do that, it's not a huge mistake. It's not a big problem, but that is the recommendation, to turn it down to P2. Okay. For an intra-aortic balloon pump, really the balloon pump should be set to then more of like a pressure sensitivity rather than going off of the ECG. That way, as you're doing chest compressions, it's sensing when the heart is ejecting, and it'll actually, just as in systole, it'll deflate. So the balloon pump should still be running. You don't need to turn it off or anything. And then for the Ecmo, so many times we'll use Ecmo as we say ECPR. Okay, so Ecmo assisted CPR. In this case, if the person is already on Ecmo, really the Ecmo circuit is going to be doing all of the circulation for you. Okay, so the heart can be at a standstill. It's bringing all the blood away from the right atrium back into the aorta through the femoral artery if it's peripherally cannulated. And in doing so, like, you won't necessarily need to do chest compressions the same way, but you would want to shock someone out of any arrhythmias that they may be having.
Perfect.
If in terms of shocking the patient, whether they have a percutaneous LVAD or a durable LVAD, you don't have to unplug it. You don't have to do anything further. If the person's on the LVAD as it's plugged into the wall, you don't have to unplug it from the wall when you go to shock the patient. I've had that as a question as well.
Okay. Wonderful. Thank you.
Excellent. So the second question that we have is, what is the significance of axial versus centrifugal flow for mechanical support?
So in the 3 devices that I discussed, the impella is the only axial flow device. The Ecmo and the Tandem heart are both centrifugal flow devices, where the actual pump is extracorporeal, so outside the body. So that's really the main difference in terms of temporary support. Now, when we're talking about more durable VAD, that plays a bigger role. The centrifugal pumps are typically more sensitive to afterloads, so we're really concentrated on getting the blood pressure down. That's really less of an issue while these patients are in cardiogenic shock.
Okay. Thank you. So the third question is, it sounds like Tandem heart is similar to Ecmo. When do I choose one over the other?
It is in a way, and I'll tell you that if the cannula in Tandem heart, which is usually crossing the interatrial septum, if it gets pulled back, then you're going to be drawing deoxygenated blood from the right atrium, because that's where the cannula then will be. If you put an oxygenator on that device, then it would be very similar to Ecmo. right? You're drawing blood away from the RV, oxygenating it, and putting it back into the femoral artery. But being that the cannula is designed to cross the atrial septum and draw oxygenated blood from the left atrium, that's the main difference. And in doing so, with the tandem heart, you're really only supporting the left atrium, or the left ventricle. You're drawing blood away from the left ventricle and putting it back into the body. So you're dropping the end diastolic volume. Okay. Now with Ecmo, it's different in that you're providing biventricular support. You're drawing blood away from the heart altogether. You're drawing it away from the right atrium. You're bringing it through an oxygenator, so you're supporting the lungs in a way. So if a patient has ARDS, that will also help support them. And then you're putting it back on the left side. Okay. Both of these devices do increase your afterload. So that's something to think about, particularly more with ECLS or ECMO, that afterload can cause an increase in pulmonary edema, as I mentioned in my talk.
Excellent. The next question is, do all mechanical support patients need to be on anticoagulation to prevent stroke?
So generally, yes, it's generally the case, okay? So if you have your ECLS patient or an impella patient that is now bleeding, has an intracranial bleed or a bleed that you're not able to control, for a short amount of time, you may be able to have them be off of heparin. I know that in a lot of hospitals, they'll have a protocol of having the intra-aortic balloon pump be on heparin, but let's say it's contraindicated for that given amount of time. If you keep the balloon pump 1-to-1, during that time, the likelihood that you're going to have thrombus form on the balloon pump is going to be a lot lower. Once you start having the balloon pump inflate at a 1-to-2 or 1-to-3 ratio, then as that balloon pump is deflated, some thrombus may actually form. So it all depends upon the risk and benefit of the patient. That being said, everything else being equal and the person not having such complications, yes, you would want them to be on heparin.
Okay. And our final question is, when do I decide to place a balloon pump versus an impella to offload the left ventricle in an ECMO patient?
So it's a good question. So it's dependent upon the amount of flow that you're providing with your ECMO circuit versus how much you really need to draw out of that LV. So it's a difference in pressure, right? So as you increase the afterload, so let's say you're running your ECLS circuit at a higher speed, greater than 3.5 liters a minute, let's say greater than 4 even, and your LV is just dilated. Typically in this case, I would try to put in an impella and get the blood directly out of the LV. That being said, the impella is a very expensive device. You use it when the patient needs it, but a balloon pump is quite a bit cheaper, okay? It, however, may not be enough to unload the LV and be able to allow it to eject, okay? So in that case, just to give you a quick scenario, we had a patient on an intra-aortic balloon pump. We ended up needing to escalate up to ECMO as the patient had biventricular failure and worsening hypoxia. Okay. With this, we were able to see that the patient really was not unloading that LV and having enough LV vent with that intra-aortic balloon pump. From that point, we were needing to upsize to an impella. And that's usually the way that it would go. If you see that the person needs a vent, there is a direct vent that the surgeon may place if ECLSs need to be placed during a surgery. There's other ways to vent the ventricle, but the most common is using the impella device.
Well, that's perfect. I know we have some participants on, no pressure. If you guys have any questions for Dr. Gibson that you would like to ask, please feel free to, put it in the chat box. We can address it. And I'll give you guys a little bit of time to type if so, and if not, that's okay. We can also conclude the Q&A session. If it's faster, you could probably also unmute yourself. We don't have that many participants on. So if you guys do have questions, please feel free to chime in. Okay. All right. I just wanted to make sure we didn't miss anyone's questions. Well, Dr. Gibson, I think you've addressed, all the questions that we have for today.
Great.
Again, thank you for being here in person, giving us your time, and also just supporting our education. It's really
Anytime.
means a lot.
All
Thank
right.
you,
Well,
Dr.
thank you for
Gibson.
putting this on.
Yeah, it was an
Of
excellent
course.
talk and very, very important too. So thank you.
Thank you.